Hey everybody, welcome to the UC Maximus Grand Rounds. Thank you so much for joining us tonight. I'm Scott Kovner.
And I am not Britt Guest. I am her trusty understudy, Whit Johnson.
How are you doing tonight, Whit?
Good, hanging out.
I love the blazer. It is incredible.
Little swag for you. This one's for you, Britt.
All right, so tonight we have a great show for you. But before we get going, just remember, if you haven't subscribed already, down below, so you don't miss any grand rounds that we put out every month, and you hit the little bell, it'll remind you when we're on the air, so you don't miss any of this education goodness. But let's jump in to what do we have lined up for tonight. Who do we have?
We've got actually a great group of faculty coming to you from our grand rounds today. We've got the great Jesse Werner, of course, reprising the role of Mel Herbert as himself. And then we've got Mike Minchin and Sanjay Arora for the guys from EMA.
It's going to be a great night tonight. And we also have, of course, recorded digitally, the host of the UC Max podcast. We've got Mike Weinstock, Gita Pensa. They're going to be coming to us. Unfortunately, they can't be here in the studio tonight, but we're still going to hear from them. We're going to get that goodness out of their brains and into our clinical practice.
All the urgent care wisdom, bring it to us.
Yes. And of course, Britt can't be with us tonight. She's busy doing other really important things. This is a huge congrats. Britt just had a wonderful baby boy. This is Luca. Welcome to the EMRAP UC Max family. Such a cute picture there. Almost looks like Mel a little bit, you know, the hair.
Hey.
The bald spot.
Sorry, Mel.
That's upsetting. He's got way more hair than I do.
We do the two extremes, the really young and the
and
the now.
Okay.
All right, move on.
But wonderful. Congrats, Britt. We wish you were here with us, but we're excited that you're at home, and we'll see you when you come back. All right. What do we else got going on the EMRAP website, UC Max website?
Yes, so on top of reviewing grand rounds, we've also got tons of content on the UC website. UC Fundamentals, our educational course for all things urgent care, just dropped a ton of videos, like 30-something videos. Approach 2 videos this time. And so it's some of our basic concepts like the approach to hip pain, approach to scrotal pain, what you can do for these complaints in the urgent care, which ones you need to send to the emergency department. So this is like a great little tool, a library going on right here. I actually am going to refer my residents to it.
Yeah, 100%, especially like for the, even if you don't practice in urgent care, the orthopedics talks on here, like these low acuity complaints, I feel like we see so much of. It's such high value. Definitely check it out. And we're going to be adding more to this series over the next few months. So this is the Approach 2 section. We have some management, some pharmacology, some peds. It's all going to be up there in the next few months overall. And we'll keep you posted as it gets updated. All right. And so now we have some current events, right? Some things have been happening since the last time we all came together for UC Grand Rounds. Let's talk a little bit about some headlines and bottom lines. So I don't know about you, Whit. I feel like half of the patients in the waiting room these days are here with some kind of viral illness. Have you been experiencing that too?
Oh, you said viral illness. I thought you were going to say scrotal pain, but yeah, that too. Okay, yeah, you're right. Cough, cold,
That's the other
fever.
Half. The other half is a scrotal pain.
Gotcha. Okay. All right.
And obviously news sources have been picking up on this too. We've got NPR, the New York Times, basically anyone who's got a platform is talking about this so-called triple-demic.
For sure.
COVID, RSV, and influenza. Last time we talked a little bit about RSV, bronchiolitis. I think we probably all heard enough about COVID to last us a lifetime. So maybe tonight we'll talk a little bit about influenza, since I feel like over the last 2 years, I really hadn't seen a lot of cases until this year. I don't know about you.
Yeah, no, 'tis the season for sure. And if you look at any of those graphs, like just the charts are spiking all around the country. So definitely going to see this everywhere.
Perfect. And so when patients are coming in, who do you test in the urgent care? Are you testing a lot of folks who come in? Like feel like I see a lot of young, healthy people who are coming with like a cough, runny nose, a fever, and they want to answer. What do you do?
I get yelled at a lot because I don't test hardly anybody.
Yeah, those
sending a lot of people home. Like, oh, you feel achy? Okay, go home.
Yeah, I feel the same way. Like when I'm at home and I feel that way, I don't like give myself an influenza swab in bed, but you know, people come in sometimes for an answer, but I think it's also important that there's actual guidelines on who to test that the CDC publishes every year. And you know, if you're admitting a patient to the hospital for so many reasons, we need to test those people for cohorting and for some other stuff. But most of the time the urgent care, right, you're not directly admitting from the urgent care, you're transferring. And I probably wouldn't swab test somebody that I was transferring to be admitted. Would you?
You know, things get lost in translation. Yeah. They're probably going to have to get swabbed again. So I'm kind of like, what's the point? I'll spare you one swab.
Totally. And I definitely know when I'm receiving patients at my emergency department, either from an urgent care or from another facility, like I'm re-swabbing.
You're still going to swab.
Yeah, our facility ones are tests because it's somehow magically better than any other test.
Yeah, for sure.
What I like to focus on though is this point. The people that you're not going to admit to the hospital, who do we test? And I think the CDC does us a huge favor and really lets us ask the question, will this change our clinical management? For the majority of people, how are you managing them? Like, what are you doing for your clinical management of these cases?
I mean, really for me, it's a whole lot just about patient education. I know a lot of people are really upset, they feel crummy, they want to know the why, and it's less about the why because it's all probably viral and more about supportive measures, right? Just encouraging them to go home, get rest, stay hydrated, antipyretics if you need for the fevers. You're going to feel crummy for a few days, but you will get through this because you're otherwise young, healthy. Whether I test you or not, this is going to be the approach.
100%. I feel the same way. The times that the influenza test changes my clinical management for patients that I'm probably going to dispo home is when I'm really looking for a source of the fever. I need an explanation. If there's something else that's going on that's complicated. Yeah. That being said, I still will offer these folks, for a variety of reasons, like a COVID test so they can follow up with the results, or they can do a COVID test at home, because like that might have implications for their work, back to school, their own quarantining. I don't know who's vaccinated in their life. You know, there's like a whole bunch of other questions that they need for that.
Yeah.
But I'm a little bit stingy about the influenza tests, I think, because it just clogs up everything. You know, you're waiting there for like 5 hours for the results. But I noticed you didn't mention in how you treat these patients oseltamivir. Oseltamivir.
I refuse.
Also known as Tamiful.
Okay. All right, let's talk about it.
Yeah. Are you prescribing this to anybody? What do you normally do with this drug?
You know, I am not myself a Tamiflu prescriber. You know, call me the devil if you want to, but I just the utility of it I find to be
question.
Yes, very small window of opportunity to even
be helpful, potentially. Totally. I'm the same way. You're in good company. You know, I think a lot of patients come, especially these outpatient people we're talking about discharging in the first place. They want some magic solution to their aches, pains, the things that you're telling Tylenol, some tomato soup, whatever, it'll go away. And so they want something, but the CDC has guidelines about who should get this drug, Tamiflu, Oseltamivir, and there's 3 groups of people that I think are important to say because these are people that, you know, we're recommending that it should be given to. These are hospitalized patients, people with severe illnesses like the multifocal pneumonia, the person that's getting admitted because they're hypoxic, their work of breathing. They also include in that point too, we're risk of progression to complicated or severe illness, so you have to use the thing between your ears to kind of figure that out a little bit on their trajectory.
And for these as well, like in the high risk, I kind of consider like the very young and the very old, kind of, again, that spectrum of people on the bookends would be someone that I would throw in here as well.
100%. And in that high risk category too, like you can review that list because it is super extensive. Anything from diabetes to a BMI greater than 40, any history of lung disease, all of those folks are at a really high risk for complications. So if you have somebody with an atypical medical history or medical problem, I honestly during this season keep this list up so I can just reference it and make sure that I'm giving it to the right people at the right time. At least that's being recommended by the CDC.
Fair enough, but what do you think about it as a whole?
Yeah, exactly. So the patient who doesn't meet these things,
Like,
they've asked a friend. I saw a Facebook ad on Tamiflu.
You did. Oh,
you know, like what, I want you to prescribe that to me. For me, I'm much more stingy about that because we know from the literature, right, like this is effective at less than 48 hours of symptoms. And I don't know about you, the majority of the patients that I'm seeing, by the time they make it to the urgent care, they make it to an emergency department, it's been about 2 days already. Yeah. They probably waited 12 hours in the waiting room, so you lost a half a day there at this point, right? And we know the best data available, the amount of benefit it provides people in this group, the low risk people, maybe 13 hours less of symptoms, maybe.
And that's crazy, right? So like when I'm sitting and talking with my patients, I take it there, right? I say, look, not only would this medication only have worked if you presented less than 2 days, but it would only make you feel less crummy for maybe 13 hours less of time. And even that is questionable at best.
Totally. So. And then the side effects, right? Like we know that there's a bunch of GI side effects, and there's some data to show there's neuropsychiatric side effects, including potentially increased risk of suicidality for a self-limited viral illness. So to me, my personal opinion, it doesn't seem worth it.
Yeah, so the literature that we looked at for this, like again, the question of 16, 13 hours of benefit was questionable, but that was the thing, the salient point that really stuck out to me was like the amount of headache, nausea, vomiting that patients got from the side effect profile, and then the renal complications that were related to the Tamiflu, and then the neuropsychiatric ones were ones that didn't seem like, you know, at 3-4 days out from your illness, that this was going to do any better than just good old Tylenol and Motrin.
Totally. Really sick people, think it's reasonable to jump in. Hospitalized people, reasonable to jump in. If you don't add it, probably the inpatient team is going to figure out what they want to do and probably add it anyways. But for the healthy, no high risk person who's just there for some fever, runny nose, I think, like you said at the beginning of the talk, good patient education, reinforcing the fundamentals for them, and to know when to return to care. Seem pretty reasonable?
I'm going to stick to that for now.
I'll do the same. Love it. So that's our headlines and bottom lines. Hopefully we don't have a quadruple demic, something else to talk about next month. I think our
brace
departments are
yourselves.
full enough as it is.
Winter is here.
Yeah, winter is here. What are we doing next, Whit?
All right, so next up, I think we're on to clinical images with the good, happy Jesse Werner.
And Jesse Werner. Let's do it. Clinical images.
What are you gonna say? All right, guys, it is time for clinical images, and I am the good and the happy Jesse Werner. I love that.
Do you want to explain what happened there?
I needed some adjectives, and she was smiling at me.
She's
so
good and
I was
happy.
like, good and happy.
I'm good and happy. I love it.
I wanted to call you classy. I wanted to say a lot of things about you, but
all those things. Thank you, Whitney. All right, so I'm gonna lean heavily on you two to identify these images and tell us what we're gonna do. All right, let's start with the first one. So the story behind this is a very healthy, like 20-something-year-old gentleman who had bumped his hand maybe a few weeks earlier and later developed this lump. Initially painless, then became just a little bit uncomfortable, and he was worried, oh my gosh, I have a tumor. This is cancer. Doctor, please help me. What is this? What is this actually? So when you examine them, it's kind of like this mobile, soft lump, no significant tenderness actually on my exam. And you
It's not a tumor. It's not a tumor.
It's not a tumor.
I was going to say contusion before you said non-tender, but
I don't
Okay.
actually think of these being associated with trauma so much as just occurring. And maybe he bumped his hand and then he noticed this thing here. But what is this?
ganglion cyst.
I
Ding,
love
ding,
them.
ding.
So
Sure
can I-
is. Ganglion cyst. Yes.
Can I tell you a great story about
I want to
ganglion
hear your
cysts?
story. Yes.
So I had a ganglion cyst just exactly like that, although mine was a little bit bigger. And I was at a EMA course with Rick Buchanan, and he goes, Herbert, have a drink. Like, okay. Herbert, have another drink. Like,
Oh, okay. I can see where this is
So
going.
give me your hand. So I put my hand over there, and with all his force, he's like, oh,
Oh, God.
and he ruptured it, and it worked.
And it felt great.
No, it hurt like hell.
Okay, and so there's one approach, one management approach. Just get your friend intoxicated and squeeze it until it pops. Some people might prefer a different option. Whitney, do you have any other management options?
I'm not as hood as Mel Herbert.
No, it's really, I don't know.
Keep it classy. For these NSAIDs and immobilization, just because, like he was saying, in the location that it is over that joint,
Yeah.
it's basically the recurrent motion of the synovial space that causes that, micro trauma that causes the fluid to recollect. And so a lot of times, like you said, they're not painful. They're just they freak people out and they ag people a little bit. So I splint them to prevent them from that overuse agitation and then give them anti-inflammatories.
Perfect, yeah, so you can absolutely do that. Some people talk about aspirating this cyst. So if you do aspirate it, you're gonna get sort of a clear jelly-like fluid, and it might reduce the discomfort for a little while, but they do have about a 50% recurrence. So just know that if you do aspirate it, warn the patient. You're also taking on a little bit of risk there because you could potentially introduce infection. So it's a risk benefit. If it's really bothering the patient, they're super uncomfortable, consider aspirating it. But if it's not bothering them, really what you said, Whitney, just kind of maybe immobilize and send them on their way. They can follow up with an orthopedic surgeon for removal if they need to. But some of these go away.
There was actually, I think, an EMA paper that we did years ago, which was aspiration versus the old school way, which was you put your hand down like that, and they get the family Bible, and they smash it.
Yeah.
And the family Bible was better than aspiration.
Was it
aspiration,
really?
The really high recurrence with aspiration.
Yeah, that is actually like the homeopathic way to address these, is literally slamming them with a book. I like to think we've come some distance since then, but maybe not. Maybe we should be slamming these with a book. So I leave that up to you. Let's move on to our next clinical image of the evening. So this is a 5-year-old, and she came in with some skin lesions. She's otherwise healthy. This is what her toes looked like. This is sort of closer to the beginning of the skin lesions. It started as a little red, little itchy, maybe a little vesicles, then they sort of burst. And then with some time, she also had them on her fingers. With some time, they sort of crusted over, maybe a little honey crusting. And importantly, her brother had the exact same rash. They had been sent home with like topical steroid cream and were not improving. What is this?
Not it.
This It looks
It's not
terrible.
a classic. It's
it looks
not
like,
a classic presentation.
It looks like they're dying, that they're fungating, that they've got leprosy. I mean, what is this?
She looks great. So actually, this was a bit, concerning because you're right. It's not your typical presentation. This is actually impetigo, just good old strep impetigo. Yeah. So normally we think about it on the face. This is what we think about when we think about impetigo, like true.
Cheated us.
I know.
Put it on a toe.
Well, I couldn't keep it too easy. So a little bit of honey crusting, usually on the face. But yeah, this child had it on the hands and the feet. And of course, it wasn't improving. It was getting really crusty. But this is just impetigo. So what are we going to do for that? How do we normally treat both disseminated and then sort of more straightforward one location type impetigo?
Slap a little mepiricin or something on it is what I do.
Perfect.
But if they've got toes and fingers that are looking like that, I'd probably add systemic treatment as well.
Yeah,
That's
great.
weird. I don't think I've ever seen that.
Okay.
I hate to admit it.
The
probably
perfect
haven't.
clinical image then, because they never
what I
come
was
in looking classic. So I'm glad I could show you that. Yeah.
You're both
So
good and happy.
thank you. I am just trying to live up to the adjectives of good and happy tonight.
I'm never
and
gonna live
I
that
feel
down.
it.
No, you don't.
So yes, you're totally right. Little mupirocin, Bactroban, covering staph, and strep, mostly strep. A lot of times this is group A strep. Okay, let's move on to our next clinical image. Now, this person came in with, he had injured his finger, had a little puncture wound. The infection had obviously spread, become worse. And at this point, when he came in, his finger was fully swollen. You might even call it a sausage digit. It was a little bit in flexion and he had significant pain. He had hemorrhagic blisters. So this is, again, not a super typical presentation. It does have some signs that we might think of for this diagnosis. And what am I talking about here? What am I describing?
You're talking about going to the ER. This
Okay, that's true. That's
this
fair.
goes into the
That's
urgent
fair.
care.
This is something you're going to have to
Send this
transfer.
to the ER.
Yeah.
Well, you're talking about like a tenosynovitis, the words you're using, but I
Yeah.
look at this and I'm like, this looks like a necrotizing fasciitis of
God.
the finger.
Okay,
Like,
yeah,
this is
fair.
bad.
Fair.
is so gnarly.
Fair. He had all the findings of a flexor tenosynovitis, and that was kind of how we started off. He was not systemically ill, but he was certainly on his way there. This is definitely something that you need to transfer to the emergency department. And you're right, this is going to require sort of big gun intervention. What do we think of classically when we think of flexor tenosynovitis? And this is more sort of a classic picture. This middle finger here
Yes,
is
yeah.
exhibiting some of those signs.
And this one's kind of like early on, right? But you can still count those, 4 signs that you were
Yeah,
talking about.
right.
That fusiform swelling that you get, it's held in flexion. You get pain with passive extension, and then pain over the tendon sheath.
Exactly. Those are the 4 Conneville signs. Conneville's. Don't know how to pronounce it. I could spell it for you, but yes, that's what you're describing. That's how we think of flexor tenosynovitis. And what do we do about this? Like, can we just give them some oral antibiotics and send them home?
Nah,
No.
you got to call OrthoHand about these
Yeah, this is an emergency.
IV antibiotics.
This is one of those hand emergencies. So if you are seeing this in the urgent care setting, this person goes straight to the emergency room. They may look otherwise totally fine, but if their finger looks like that, they're going to the emergency room. And they need IV antibiotics. We're covering for big guns here. So a lot of times we're using vancomycin and we're using Zosyn, Piptazo. It's probably how I should say that, Vanc and Piptazo. Got to cover all those big antibiotics, all those big bugs, MRSA. Call ortho. This is a hand emergency, needs to go to the operating room for washout.
Do you have a chapter on this in Compendium?
We actually have a beautiful chapter on this written by Dr. James McHugh.
Okay.
And Danielle Campaign is the AE of this. We cover this, and we've got some great images there as well.
Thank you. You can read more on Compendium. All right, so now it is time for our mystery image. Yes, here it comes.
Gasp.
This is our mystery image. So what does that mean for you, the viewer? It means the first person to tell us in the chat what this is, the correct diagnosis, what this is, gets a pair of AirPods. You win at the end of the evening. The very end of the evening, we'll come back to this and we will reveal the answer and we will choose our winner. All right, so there it is. I will tell you one hint. This is a child. This is pediatric. All right, so now it is time. We are going to go to papers of the evening.
Hello.
Welcome, everyone,
Welcome to the EMA.
I'm Mike.
And I'm Sanjay.
Oh, I thought you forgot for a second.
No, I didn't. So they gave us a light board today for this presentation.
And we promise we will make them regret it.
Yes, absolutely. And hopefully you guys will enjoy it. So Mike and I review 20 papers every month on the EMA program, which is part of the EMRAP family. And so they invited us today to come talk about 2 papers which have some relevance to the urgent care audience. So I'll be going first, and I will be covering the immobilization of torus fractures of the wrist in children, a randomized controlled equivalence trial from the UK by Perry et al. In the Lancet, and this is the FORCE trial. So what they did here basically was seeing wrist fractures is common. The mystery image was just one of them, as you guys saw. This is a different fracture, spoiler alert, so that one's not a torus fracture. So wrist fractures are very common, and torus fractures or buckle fractures make up about half of pediatric fractures. So certainly everybody listening has probably seen one of these before. And the question when you get one is kind of, well, what to do? Because it doesn't really look like a fracture. It sort of looks like a little bend on one side of the bone, which is what it is actually. So are you supposed to immobilize this thing or not? And I think traditionally we feel like something looks broken, let's immobilize it. That's the way healthcare providers have been taught to think for eons. So changing that is a little bit difficult. What they did here was they took almost 1,000 pediatric patients, 1,000, that's right, it's a big trial, that's how it got into the Lancet, with torus fractures, isolated torus fractures, and randomized them to one of 2 different groups. They got randomized to either a immobilization, which was largely done with a splint, kind of like a Velcro-looking splint, or just nothing. They didn't totally do nothing. They did gauze and a bandage because in some pre-trial work, some focus group work, they learned that parents would actually not accept being enrolled into a study where you did absolutely nothing. So it was immobilization versus gauze with a wrap. And their primary outcome of interest was pain at 3 days, but really they looked at a host of secondary outcomes. Pain at lots of different intervals, 1 day, 3 days, a week, all the way up to 6 weeks, and then they looked at functional status at 6 weeks. They looked at patient satisfaction, parent satisfaction, all kinds of different things. This was a well-done study from 23 different emergency departments in the United Kingdom. And basically, at the end of the day, they found total equivalence. So in their primary outcome of pain at 3 days, it was the same, a rating of about 3.2 on the 10 scale, regardless of which group you were in. Pain at a week, pain at 6 weeks, satisfaction at the end, all the same. There were a couple of minor differences, and both occurred on day 1. In day 1, the use of analgesics was a little bit higher in the bandage group, and the parent satisfaction was actually a little bit higher in the immobilization group. And I think this sort of speaks to what we have always done and what we know. Parents want something done for their little kid when they have a broken arm. So I think that probably explains that, but it all washed out at the end. One more thing to note is that about 10% of the kids in the bandage group actually crossed over and ended up getting immobilized. So some people have said, hey, that maybe that means it doesn't work 10% of the time. I think that's probably not right. It just means care was escalated 10% of the time in one group, and we don't really have a number for amount of escalation of care in the rigid splint group. Maybe they come in and got casted at some point in time. So I think this is a really well done trial that can change the way you practice, and it largely speaks to a theme of de-escalation, which is good. So if you're somebody who casts these things, stop doing that. Start using a splint. If you're already somebody who uses a splint, you're probably at a happy medium, but you could start the discussion with the parent of saying, hey, maybe this thing doesn't need any immobilization at all. But I think we can all agree one nice message, particularly as the dad of 2 toddlers at home, if I was to say to somebody, keep this thing on when you can, but if they take it off or they need to get in the bath, they don't want to keep it on, that's okay, because we have pretty good evidence that if they wear absolutely nothing for 6 weeks, they're going to do just fine. So I think this is a really well done trial, and next time you see that patient with a torus fracture, make sure you don't feel like they have to run to the emergency department for some orthopedic consultation, because that's not going to happen, and all we're going to do is find a little Velcro splint to put on them at most. And I think that Geeta actually had some thoughts on this one that she wanted to share, thoughts on this paper. I think.
Maybe.
Or maybe not.
Okay, so I really liked this paper on torus fractures of the distal radius in kids because it was a really well-designed study. I feel like it settles the question fairly well, at least in my mind, and it hopefully will help some of the variability in practice. Well, let me take that back. It's not going to solve for the variability problem, but it's going to at least let us know that all of these things are equivalent. And the reason I say it's not going to solve the variability is because I think they make this point rather clear that parents of children who have these fractures are generally unsatisfied with you offering to do nothing. At least that's my feeling on it. I usually encounter resistance even with my typical practice, which is to offer them like a Velcro wrist immobilizer. And in the past, what I've done, and this might change based on this paper, in the past, what I've done is if I'm working in the urgent care and you don't have a size small enough for that child, which actually is a frequent occurrence where I work, I would make them a fiberglass splint and just tell them you can take it off whenever you need to. You can take it off at bath time and then just, keep it on until the pain gets better, and then follow up with your pediatrician. And there was always a lot of resistance about not going to the orthopedist afterwards. And I tell them you're welcome to, but it's probably not necessary. And there would certainly, I feel like, be resistance to being like, you don't really need anything for this. But it's really nice to know that you could get away with it. So I might be sort of emphasizing that point now that there's evidence behind me to say this has been well studied and the evidence suggests this is totally equivalent, but if you feel more comfortable to have this removable splint on your wrist, we'll do that too. But this is going to heal well, try not to worry about it. That's going to be the take-home message. And it's just nice to have a little bit of reinforcement behind that.
So we got a question in the chat, and it was what kind of a splint you use. So it's a volar splint for the most part. You can use one of those removable Velcro volar splints is just fine. If you don't have one in the right size, you can make one out of fiberglass. And if you don't have, fiberglass or plaster or something like that, you can just go with the do nothing option or tell them to go to the drugstore or something like that to buy something. And now I'll pass it on to Mike for paper number 2.
All right, well, paper number 2 is one that I really love. It's called Cosmetic Outcomes of Simple Pediatric Facial Lacerations Repaired with Skin Adhesive compared with skin adhesive with underlying adhesive strips, a randomized controlled trial by Munz et al. In pediatric emergency care. And it's a mouthful, but it's really, really important. I love it for EMRAP, but I love it especially for urgent care wrap and for this audience. And the reason for that is that obviously closing simple lacerations is a mainstay of what we do. When you can close it with skin adhesive glue or Dermabond, as it is often called, it's great and easy. When you have to use stitches, not so much. And that's some of the times where we get into this problem of having to send kids to the ER to do procedural sedation, etc. Glue works great when the wound is relatively small, relatively non-gaping. But when it's a gaping wound, it's really challenging. And we've all had the experience of trying to close a gaping wound on the scalp or on the face with one hand and applying Dermabond with the other, only to glue your gloves to that poor child's skin and then tear open the wound as you try to remove your gloves. Doesn't do great for patient satisfaction, and it doesn't repair the wound. Steri strips, on the other hand, or tissue adhesive strips, are wonderful, but they have a tendency to peel off almost immediately. And then, of course, they also don't have the tensile strength of glue. So the question that they're asking in this paper is, what about using them together? Can you approximate the wound with Steri strips and then apply skin adhesive glue or Dermabond over the top of it to then give it that tensile strength? Or when you do that, basically, does that whole amalgam of Steri strip and glue just kind of fall off and result in either poor cosmesis or a higher incidence of wound dehiscence. So, in this randomized controlled trial, which was done at a single site, they enrolled 120 children with fairly simple facial lacerations. They were all small, they didn't involve the mouth or the vermilion border, so these are your run-of-the-mill, kid falls down, has a bump on a laceration on his forehead kind of injuries. They had 120 of the kids, thank you Sanjay. They were mean age 4, so this is really important when we're looking at pediatric work. A lot of times they report a study of 120 kids, but they're all basically 17 and a half years old, so it makes it less relevant. These are little kids, average age 4 years old. They randomized them to either dermabond with nothing else, so you just put the wound, approximate it the best you could, and then put dermabond over it, versus dermabond that has been pre-treated with these steri strips, and then put the dermabond over the top of it. As I said, the key outcome was skin cosmesis, and this was assessed several months after the application of the various strategies for wound closure. And then the secondary outcomes were stuff that we really care about in the urgent care or in the emergency department. And those included things such as the reported ease of application, how long it took to close the wound, and importantly, the incidence of any kind of infection or wound dehiscence within 7 days. They had excellent follow-up in this study for the secondary outcomes, that is, the ones like how often they had the wound dehisced, and a little bit of a higher than desirable loss to follow-up rate for the long-term outcomes. But nonetheless, the results were overwhelmingly equivalent. And that is that if you close a wound with dermabond or close the wound with steri strips, the clinical outcomes are the same. There was no reporting of the amalgam falling off. There was no higher incidence of wound dehiscence, which was very rare in both groups. The only significant difference in the analysis was the time to apply the different agents. And it was about 1 minute longer in the group that received the skin adhesive strips, so the steri strips. And I think that makes sense. They applied them first and then applied the dermabond. But in either case, it was roughly 2 to 3 minutes to complete the procedure in its entirety. I think the main thing to consider here is that I personally believe this is a fantastic strategy when you have a gaping wound. This study shows equivalence across the two, but the reason I believe that the skin tissue strips plus dermabond didn't do better was because they limited the study sample to kids with really simple lacerations, generally speaking small, less than 2 centimeters. They didn't have to be less than 2 centimeters, they just happened to be less than 2 centimeters. And I think that reduces the ability of the steri strip to sort of make this wound come together a little bit better. But having said all of that, I've never seen a randomized controlled trial on this topic, and this gives me confidence to know that at least if you feel you need something to hold that wound together and you don't have another person who can do it for you, a skin adhesive strip is an evidence-based approach to doing that. And then you can apply the dermabond over the top of it with excellent cosmetic results. Now, I think we can turn it over to Geeta, who had some thoughts on this paper as well.
Hey, everybody. So I thought this paper, looking at the use of dermabond alone versus dermabond over steri strips in pediatric facial lacerations, I actually thought this was very interesting. I use both of these techniques, and I had never really thought to ask the question about whether they were cosmetically equivalent. I think I just made the assumption that they were, which was very unscientific of me. So it's good to know that I have not harmed anybody, cosmetically speaking, by using these interchangeably. I do think it's important, though, to think about this and the use of what I call mixed media in terms of laceration repair, especially in kids in their urgent care, because in the urgent care, we are typically not sedating children to do laceration repairs. And some other time we can talk about maybe using intranasal meds and things like that in the urgent care. But most practitioners in the urgent care are trying to finesse this laceration repair with a combination of restraint and soothing and distraction and speed. Like, speed is of paramount importance in this scenario because the kid is trying to move their head and bolt for the door, and you are just trying to get this done as quickly as possible, but of course you want it done well. And so slapping a steri strip on there and getting everything opposed and making sure that it's closed as best as it can or opposed as best as it can be before you put the glue on, I think is actually a really great technique. So now knowing that those two methods are probably cosmetically equivalent is actually really helpful because it probably will help keep it top of mind as something that just makes your life easier. Like, it makes your life easier in that scenario to think about, like, oh, I could just put a steri strip on that and then put some glue on top of it once it's set the way I like it. That's where this paper landed for me.
Well, thank you all. As we promised, we would make Mel and the team, Whitney and Scott, regret letting us use this great lightboard technology. I hope that it's deeply offensive to everybody.
And now we are going to send it over to the next segment of today's exciting urgent care rounds, which is the Jeopardy show. So let's get to it. Thanks
do
all
it.
for listening.
This is Jeoparty!
All right, welcome back, and shout out to the guys at EMA. Thank you guys so much for coming and presenting some of these great papers here. Obviously, you can head over to EMA to catch more of their discussions. And let's get right to it. We are going to play Jeoparty! And these Jeopardy questions are going to be based off of our key topics of urgent care. Actually, Britt Guest and the crew put together a great conference for urgent care topics, and we're going to do a little bit of a review with yours truly. We've got Dr. Scott Kovner, Dr. Mel Herbert, and the good and happy Dr. Jesse Warner.
Thank you.
Thank you. I'm never going to live
Just
that
don't
down.
submit
gonna say it.
my final score on this to ABEM or anything. This is going to be rough.
This is ageist. I'm going to lose so badly because I am elderly, and I don't think it's right.
Well, we all know who's actually going to win, and that's the folks that work in the urgent care,
Yeah.
but we won't knock you guys. It's okay. All right, so the topics that we've got here, we've got OB STIs, okay? That is STIs in the pregnant patient.
Okay.
We have classics, which are going to be classic visual diagnoses.
Okay.
We have decisions, which are going to be clinical decision tools, aka Corpendium calculators. Winter is coming, child. That is going to be all of your pediatric respiratory illnesses.
Okay.
No bones about it. That's going to be ortho radiography related stuff. And then on the pharma, which is going to be all about Dr. Sean Nort's area of interest, is going to be meds. All right, so instead of doing Rochambeau, we're just going to go with the most graceful individual in the room. We're going to start with Dr. Mel Herbert. You've got the board.
Age before beauty.
What do I do?
So what you're going to do is
Should have been here for the run
oh my
through.
God.
There's a little show that was on TV. Alex Trebek.
Alex
hosted it
Trebek
at
is
one point.
rolling in his grave right now.
Do you know the Saturday Night Live version of this where they have Sean
Yes.
Connery playing? That's this guy. Your mother, Alex. Your mother.
Sweet baby.
And to be clear, we've never seen any of these questions before. This will be the first time for all of us.
Yes.
We're at midsworth.
We're all having
This
significant
is
test anxiety right now.
Already incredibly cringy, but let's get started. Okay.
So do I choose a thing? Like,
Yeah,
give
so
me
you're
classics for 100, Alex.
All right, so we'll start with classics for 100. Answer. Dr.
All
Kovner.
right. What is bad man? No, what is paronychia?
That
All right.
is correct.
So do I push or do I let go?
You push. You press the
you.
button.
Don't
You
tell him.
wave your hand in the air, spin around, touch it.
Okay.
Okay, so paronychia, right? That's a classic image of a paronychia. The main teaching point here is that these incision and drainage is kind of the way to handle those. So this comes into the urgent care. You can very well grab a scalpel and get after it. All right, so Scott Kovner, you've got the board. Where are we headed?
Let's do no bones about it for 100.
All right, answer. Jesse Warner.
You know, I'm not great with the hand, but is there a fracture of the fifth metacarpal there?
AKA.
Boxer's fracture? Is that what it's called? What's a fifth? I don't know.
That is, stop questioning yourself.
Okay, that's a boxer's fracture.
That is correct. That's a classic boxer's fracture.
Okay, all
Have
right.
some faith. Have some
It
confidence.
was the hesitation. I got
Bring that good,
very anxious.
happy soul. Okay, so
back to
boxer's fracture.
and happy.
Teaching point here, though, I actually want to show you guys type of splint, which is important, is going to be an ulnar gutter splint, okay? And all of these you can find like in corpendium as well, but I find myself always having to review. So 4th and 5th metacarpal, put them in the ulnar gutter splint.
Can I
All
do
right.
2 pearls on this?
Yeah.
First of all, boxers don't get this fracture. This is street fighters who fight like this. Boxers hit actually with here because there's more force. And actually the English studies say unless it's really, really bent, they don't do anything for them because the English punch each other in the face all the time. So there you go. Go on.
Mel, can you throw that punch one more time for us?
Yeah,
Solid.
it's a real
little
street
too close
punch.
for
Real street
comfort.
punch.
I heard nothing. I only saw that. So, all right. Jesse, you have the board.
I do. I'm excited about. I just want to spend the time since I am holding the board, but I know we have to keep going.
Oh my God.
Oh my gosh.
Getting
okay.
cringier.
I'm gonna go to Winter is Coming, Child for 200.
All right. Answer. Dexamethasone, racemic epinephrine. Jesse.
Croup.
Oh shit, I was faster than you.
I don't know.
Yeah,
I mean, the board.
that's-
This is science.
Answer is correct, actually.
Mine's broken.
Croup. All right, so this is just talking about some of those general management strategies, right? Things that we always have to think about in the pediatric patient, especially this time of year. With croup, remember, not albuterol. You want to use racemic epi and dexamethasone, your steroids. All right, Jesse's board's still yours.
All right, just saying, the only girl out here, winning, Let's go with decisions for 300.
Okay, we've got history of heart disease, abnormal BP, abnormal QRS, prolonged QTC, and a predisposition for vasovagal cause. Scott.
All right, I think this is going to be Canadian syncope rule, only because I think they're the only people thoughtful enough to talk about a predisposition of vasovagal causes in a decision rule.
Yes, all right, that's correct. So this is the Canadian syncope rule, and remember, the point here is not to remember all of these off the top of your head like these weirdos. The main point here is think about it and know where to go to find this information so that you can do risk stratification. And a lot of these decision tools that we're featuring here are ones that can be applied in the urgent care to figure out if this is a person that can stay in the urgent care or if this is someone that needs to go to the emergency department for further evaluation.
I looked at that list and thought things that cause syncope.
I would have gave you
Those are
Alex, this is not fair, Alex.
It's not untrue.
All right, Scott.
Let's do, I like clinical ones. Let's do classics for 300.
Answer. Jesse.
Those are aphthous ulcers.
Not correct. Anybody else?
I'm going
Scott.
to go Coxsackie, hand, foot, mouth.
Yes.
What is?
What? I just
What
saw
is?
the mouth.
You
Where's the
know-
hand and the feet?
Yeah. And where's the butt? Because it's hand, foot, mouth, and butt.
That's true. It
this
does
is
show up on the
cool.
butt a lot.
You know what? It is just like a group of EM doctors to try to shade my question for me. I just want to say, we get the general principle here. This is classic hand, foot, and mouth. And this is something that, parents might be a little bit freaked out if they're unfamiliar with it, but these are visual diagnoses, right? Things that you can see from the door, no testing required, and it's about supportive measures. So for this, Tylenol, Motrin, a little bit of viscous lidocaine, mainly for the pain for them, and just make sure that they stay hydrated.
I just think it could also be like herpes stomatitis early on and other things. I'm just saying. I wanted to see the buttocks.
Yeah.
All right. Well, that's 1,000 points for Mel Herbert because this is like whose line is it anyways? The points mean nothing and I get to do what I want. Sure.
I want some.
All right.
Actually, I have a question. Do I lose points if I get it wrong?
Yes.
Yeah.
Jeopardy. This is Jesse's first time seeing or playing Jeopardy.
Yeah, me too.
Well,
So-
I have other things to do with my
Her
time.
good and happy self actually needs to watch a few YouTube videos, but we'll leave it at that. Scott, you still have the board.
Now I feel like a weirdo for watching Jeopardy because
Yeah.
I'm like the only person
I
up
think
here who
that's the
watches
real
it.
thing. That's really
Yeah,
the problem.
I mean, yeah.
Yes.
All right, let's do classics for 400. Let's get the images going.
Classics
I like
for
these.
400. Here we go.
All right. I'm going to say chicken pox, although some of these things are a little umbilicated. I don't know.
Umbilication.
Yeah, umbilication. But they all look same stage. I'm gonna say chickenpox. What is chickenpox?
Yes, so this is a classic primary varicella rash, aka chickenpox. Again, here, visual diagnosis, supportive therapies. All right, let's go back to the board.
Starting to wonder if he put these slides together.
Wow, some shade here on the board.
The only cheat code is that this is all in key topics for urgent care. Go
right.
back
I
and
thought I
watch
went
the
to that, but
content.
Weren't you there? Weren't you part of that?
Let's do. Is it mine? This
Yes,
time? Yeah.
still
No,
you.
no bones 200. Let's do ortho.
Oh, I
Dr.
did that too
Herbert.
fast. No, that's a Mason fracture.
That is correct. Bonus
I'm just going to
points.
start pushing this thing.
I know, that's a good, I might too.
Bonus points for type of splint.
Posterior long leg.
That is also correct.
Wow,
For
I'm
the
done.
win.
I'm done.
Was that was the
right.
day of UC fundamentals? That was the day.
I went.
Mason, new fracture. Remember, if the patient comes in with complaints of ankle pain, don't forget to do a full physical exam of the entire lower extremity, because we oftentimes forget to palpate that fibular head, and you might miss this if you're only getting dedicated ankle films. So, things to note there. All right, and Mel Herbert comes through
ready
and
for this?
takes control
Yeah.
of the
Ready for this?
board.
Let's do farmer for 500 because there's no way in hell we're going to get this.
Sean Nort. Okay, so we've got otitis externa with a TM perforation. Dr. Herbert?
Cortisporin otic suspension.
What?
Cortisporin otic suspension. Is this ageist again? Sean.
What's the generic word?
I don't know.
Ciprodex, but that's not my answer.
If I lose my 200, I'm going to be pissed.
That's the non-generic.
This is like, I put it in the generic, and I'm trying to think if otosporin.
Let me look it up on
counts
Quick.
for-
Corticosporin,
No,
otic
it's
suspension
It's
with
ofloxacin.
ofloxacin.
Ofloxacin, yes.
Ofloxacin.
But here's the thing. So ofloxacin, right, is important to use otitis externa with a TM perforation because the Cipro is ototoxic. And so if you've got a compromised TM, you can't use an ototoxic agent.
Yeah.
Sean, let us know if
Yeah, Sean,
Mel
talk to me.
Herbert's answer by default is correct. He's cheating right now and probably
Yeah,
texting
he's
you.
looking up. But also, like, you prescribe PO antibiotics for these people too, if they have, like, if it's perfed, right? That's the other thing, right?
Yes,
Okay,
yes.
cool.
All
Sean,
right.
get back to me, bro.
And the suspension versus solution, traditionally the reason we like the suspension is because it doesn't hurt as much. So the idea is that when you put the drops in, it can really sting and be really irritating. So that's why we use suspension instead of solution.
Yes.
Thank you.
I love this. The pearls are coming out.
Love it.
So we had a very awkward turtle situation, so we're just going to go to Mel for the board.
Okay, Mel.
Farmer for 400.
This guy.
Corneal abrasion in a contact lens wearer. Dr. Herbert.
Well, it's got to be Cipro drops.
It's going to be,
I hit
yes,
it.
it's going to be a quinolone, just in general, right?
You don't like
So-
Cipro
Can I
now?
get points for why?
With the
Can I get
answer.
points for why?
Yeah, drop some knowledge.
Thank you. Pseudomonas coverage.
Yes.
I cover Pseudomonas.
Keywords
That's
here.
worth like 1,000 points, right? I'm pretty sure.
You know what? You get 1,000
get
points,
1,000.
and
You
you
get
get
1,000.
1,000 points, and you get negative zero.
What do you use now?
Negative
Was
zero.
Cipro is old? Was that ageist? Is it not Cipro anymore?
So I use a general, I just say quinolone in general, only because the teaching point here is that you got to have the pseudomonal coverage if it's a contact lens wearer.
Don't make fun of me when I get
Wow,
upset.
these EM docs coming from my throat here. Okay, well, so
We're all competitive
now you
sports
did
players.
get that, and you've got the board still.
All right, let's do something I know nothing about. Pediatrics for 500. Winter is coming, child.
500.
All right, antitoxin, erythromycin, penicillin.
Only one thing I can think of. This might be diphtheria. Is it diphtheria with the
Yes.
antitoxin?
I
Okay.
did not
Yes.
put that together.
Yeah.
Tell
I was
us
like, what's the
some,
question?
like one tidbit you remember about like that textbook presentation.
So
Anybody?
this is that I don't know if they call it the pseudomembranous plaque.
Pseudomembranous.
Yeah.
It's really impressive when you see it back there. It's like it almost looks like you can just peel it off on the back of the throat. The bullfrog neck, is that right? They get like the really big neck. And then also it's cardiotoxic. It produces a toxin, and that's why we give the antitoxin. I think that's all I know about.
I just remember the
That's all we
membrane.
know. He only knows
Yeah.
everything about it. That's fine.
Fair enough. All right, Kovner, to the board.
You know what? We've been really, neglecting the STI side. Let's do
Yeah.
300s, OBSTIs for 300.
Ah, yes, some great videos and key topics on the OB population, but we've got azithromycin or amoxicillin. Kovner.
These are things to treat the STI, I'm guessing, so I'm going to, chlamydia. Would that be appropriate? All right,
That's correct.
chlamydia.
Amoxicillin.
All right, yeah,
When
so-
do we use amoxicillin?
So you can use amoxicillin as kind of a second line therapy for this. Really, the azithromycin 1 gram PO is sufficient, but
Okay.
Yeah,
they
that's
highlight
true, I'm
that
like,
second
amoxicillin.
line.
Can you use
Amoxicillin.
amoxicillin?
I don't usually reach for that. Okay.
This is in
Alright.
the OB population, right?
Yes.
So it's that way you're not talking
Pregnant patients.
about pregnant patients. That's why.
All right, Kovner.
All right, let's do decisions for 400. See what that's about.
We have age greater than 40, neck pain or stiffness, witnessed LOC, onset during exertion, limited neck flexion. Jesse.
Is this the subarachnoid, Ottawa subarachnoid hemorrhage rules? I had to think about it. It came.
Squadron, I know you're screaming at the screen. This is the Ottawa subarachnoid hemorrhage rules.
I knew it was Canada because
Ottawa,
they are so
because
good.
it's-
The Toronto,
Validated.
Saskatchewan.
Oh yeah, the old Quebec UTI calculator. Yeah.
All right. So again, with any of our decision rules here, obviously, as far as risk stratification, which patients you can consider with their complaint of a headache, keeping in the urgent care for just supportive therapies versus who you have to have a higher suspicion for something dangerous or gnarly and you want to send them to the emergency department, consider taking a look at the Ottawa subarachnoid hemorrhage rules. Right, Jesse?
Okay, let's go back to OB's STIs and let's.
Oh no.
Yeah, let's do that.
You're the one pulling 500 over here, dude.
Yeah, let's do 500. Yeah.
Yeah, let's do that.
Bangers. Ceftriaxone, azithromycin, and metronidazole. Jesse?
PID.
That is correct.
Those are too fast.
Super serious, right, in the pregnant population, especially. Point
happen.
here, all of those medications plus admission. So if you have a OB patient that comes into the urgent care, this is not a patient that you're gonna treat and street. This patient needs to go to the emergency department to be admitted. High risk for preterm labor, with these untreated STIs in general, but even more so if you've got pelvic inflammatory disease.
Yeah, there's been about 6 reported cases in the world literature. That's fine. Whatever.
All right. Someone's a little
Someone's
sour.
bitter.
Where's the Canadian sort of loser criteria? Where's that at?
So
Just go. Go on.
Okay, let's stay on this one. I'm feeling good about this. Let's
God.
do 400. Mel hates it. It's perfect.
all right. Tinidazole.
It's got to be the trick. It's got to be trichomoniasis.
It ain't tricking if you got it. This is tricking.
2 grams does the trick. That's how I remember.
Tinidazole or other one.
Metronidazole.
Yeah, so I kind of threw a little second line
did.
agent in there as far as another option that we have for consideration. But tinidazole or metronidazole are both sufficient antibiotics to be used in trichomoniasis. All right, Scott.
Let's do classics for 500.
We're running out of time. He's going big.
Going big.
We should go big.
Well, it looks better on that screen.
What are we paying attention to here?
All right, I'm going for it.
Yes, go.
All right,
Yeah.
so the first thing I thought, sorry, this is going to be a winded answer. I looked at his lips and I was like, there's some red stuff there. Is this some weird, what is it, Peutz-Jeghers syndrome
Oh, geez, I don't know
thing?
what
But then I
you're
was like,
talking
no,
about.
this is urgent care. Then I was like, look at how jacked his masseter muscles are, his jaw. But then I looked at his neck and then I was like, that guy's not jacked. So is this parotitis?
Yes.
Okay.
God, Scott.
How?
I mean, it's look
You're
how
a
big the
savant.
side of his face is.
I know, I'm looking
I
at his jaw.
was thinking trismus.
Did he swallow somebody?
I'm like, he's not opening his mouth very
I tried not
wide.
to cheat by saying look at the whole picture, but I
Look
like
at those
this.
cheek lines. Those
I
are like,
like
yeah.
this
This guy
for
watched
visual
every
I
day.
know,
diagnosis.
come on, Scott. He planned the conference, so
Yes.
he
Mel
has
just
an
pulled a
advantage.
buzzer job. He's about to be out. So I like that visual image of bilateral parotitis because obviously it can look very disconcerting, right? But know that most of the time this is actually a non-infectious pathology that can come just from dehydration. There are some infectious etiologies for parotitis, both viral and suppurative. Most of the time it's viral, and I brought it up because of our prior discussion about 'tis the season for influenza. Influenza A actually can predispose you to parotitis as well. Here, supportive measures is kind of the way to go as long as it's the viral or the non-infectious cause. All right, how are we doing on time? Looks like we are getting close
I need to get some more
let's-
points, so we have to keep going. Yeah.
All right, so we are gonna
To find
go.
it out.
Let's go one more and then on to Final Jeopardy.
All right.
Scott?
Let's do winner's coming child for 400.
Last question. Augmentin or rifampin for post-exposure prophylaxis?
I can't remember. I can't remember. And I can't lose my points.
What's pertussis?
Yeah, I was thinking too.
Answer.
It's like a Zithro though, right?
And now I've lost
Hib.
all my points.
Hib. And this, again, most applicable in the unvaccinated pediatric population. Now, with most of our population being vaccinated, we don't worry as much about Haemophilus influenzae. However, there's changes in the times and some people that may not be vaccinated, so still something to consider. All right, so let's go into our Final Jeopardy here.
Yes, let's do
Okay.
this. Let's just do
Okay,
this.
so remember, with Final Jeopardy, we're
Sticky
gonna
brain.
show you the question. You're going to write down what you think the answer is, as well as how much you're willing to bid on your choice.
Mel's clearly cheating. He's looking at my
Okay.
board.
Let's get some theme music going on here.
Wait, I don't understand the question.
Yeah. What do we have to write about?
Nursemaid's elbow.
What do you
does
want
that
to
mean?
Identify it. Identify the fracture.
Okay.
Identify the fracture.
So what is a nursemaid's elbow?
Oh, what is a nursemaid's elbow?
Yes.
Yeah. Can't write that fast. Okay, we need another verse in here. We also have to put how much we bet, right?
Yeah.
If I misunderstood this question, I'm going to be pissed.
Boom, boom.
All right.
All right.
It's. I don't.
Right. So we. Well,
Oh my
Jessie
God! I
decided
just
to
showed the answer.
start with
Just
herself.
change mine real quick.
Oh, yeah, hold on. That sounds pretty good.
You're going to start first because you get the least amount of
Okay.
points, I think. But so this is
Hey.
nursemaid's elbow, and what I'd like you to identify is the type of fracture.
Well, so that is an annual. It's where the radial head is out of the annular ligament.
Let's see your answer, and then show us how much you're willing to.
900 points.
Annular radius is
Then right?
Yeah, that's right.
this. I mean, this goes to the host. The answer is also dislocated how she wrote it, so I feel like that's also pretty
All
good.
right, fracture
Yeah.
or dislocation. I shouldn't have said that. I should have said fracture or dislocation.
The radius is out of the annular ligament. Can call that a dislocation, and it's 900 points.
Okay, yeah. It's like, how are you writing this?
It's
What are you
just a little
talking
messy. There's an arrow here. A little arrow.
about? Yes. So Jessie gets her 900 points.
Yeah.
Mel Herbert,
Annular ligament dislocation,
80
700 points.
oh, I thought it said 8,700 points. I was like, you don't have that.
8,700 points.
All right, and finally,
Am I only on
Dr.
the
Coder.
subluxation of the radial head? Is that it's the other way? It's like it's inside the annular ligament. It just that's the thing that comes out.
Let's look it up
I
in
gotta
compendium.
give you points for that
I
because
think
it is a
technically-
sublex, but it's from the annular ligament dislocation. So this is kind of not fair
If
because
you want to be medical about
right.
it,
That's
I
what
mean,
it's like, yes,
All right.
but
that's
But
just
it's-
a medical
it is
term.
Yes,
We
so-
described it in layman's terms.
Which is a great segue.
Well, anyways, speaking of layman's terms, that brings us to the end of this game. And as you can see, we've got a lot of experts weighing in here. We've got Experts Corner, we've got the experts of EMA, but what if we had information straight from the layman's? Let's see Layman's Corner.
Welcome back to Layman's Corner.
And that is Josh.
And I'm not Tom, and we're going to be talking about. Welcome back to Layman's Corner. We're going to do a little bit of a refresher.
Fobble.
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 Is it Circle of Willis? Anticoagulation.
The ED turkey sandwich. Subarachnid hemorrhoid.
5 Barrel Protect.
Refresher course. Stretch it out, Josh.
Hey. Bear Anti-Venom.
First attack.
Teddy attack.
Second attack.
Fatal.
Always
fatal.
more venomous.
Which we like to call what the papa. Welcome to the party, pal. All right, so Circle of Willis.
Yeah.
Die Hard. Die Hard 2. Die Hard 3.
Two camps.
Two camps now. There's two camps.
That's your
Anticoagulant.
That's your tent.
Procoagulant. Was there another one?
Die Hard with a Vengeance. Is that
thought
3?
that was 3.
Oh. Was there more?
Yeah, there was the one with the Harrier jet.
The one with the Harrier jet? I don't think if we can't remember, how are we supposed to get them to remember?
There's so much vitriol on both sides. Procoagulants, anticoagulants.
Take your 100% feelings about these things and just cut it in half.
Just cut it half.
50% for me, 50% for that guy.
That's right.
over
50%.
there.
Look.
And now look, we're
Common ground.
we're together on this.
Sludge.
Sometimes a little anticoagulation, sometimes a little coagulation, but at the end of the day, everybody enjoys
It's the sludge,
sludge
of
of
love.
Hold on, and this?
All right, everyone, welcome back. Hope you enjoyed some of the Layman's Corner pearls. In the chat, just throw out if you're a pro-coagulant or anti-coagulant. I personally like the bear venom. Anyways, now we're going to do a Bouncebacks style case, courtesy of Mike Weinstock, who couldn't be here with us tonight in the studio, but he sent us some information. He's also recorded a little bit that we'll talk about at the end. Again, no one here besides me knows anything about the case, so you're going to see them reason through some stuff in real time.
Just like you didn't know anything in the last case.
Listen, I did not have anything to do with those slides. I'm sorry that
Somebody went to the urgent care conference.
You know, I actually have been paying attention. But hey, all right, so let's jump into it. Are you guys ready? So you can just ask questions whenever. We've got some few clinical images and stuff to pull up too if you need any of that information. But this case takes place inside of an urgent care. Okay, it's a 42-year-old guy who comes to you.
Send to the hospital, admit him.
All right,
Cheat
that
codes.
concludes our bounce back. He's 42 years old. He's coming to you. It's a Sunday. It's been about 4 hours since he just finished playing a great rec soccer game, really inspired by the World Cup. And he's complaining of some back pain that started, during the soccer game. He's not sure if he had a weird slide tackle or something, and it's escalated over the last few hours, and it just hasn't gone away. And so that's what he's here to see about.
Where in the back?
So he tells you it's like hard to localize. He's kind of just doing one of these. It's like, it's just like in my back here. It kind of feels like, and he's pointing to like the middle of his back. It's like right along the line of the diaphragm, if you imagine drawing that on his back. He just said it's really achy, and he can't really pinpoint exactly where.
Go.
It started after he had a slide tackle, you said?
He's like not really sure in the game when it happened, but like he had a few rough falls in the game. But he just remembers like it started in the game very clearly when they were playing, and it was a very competitive game, and it's continued to get worse ever since. And it's been 4 or 5 hours now.
What kind of protoplasm are we dealing with here? Is this a fit and healthy person, or has he got 1,700 other medical problems?
He's a 42-year-old guy.
play
He
soccer.
immigrated from South America about 10 months ago. He otherwise doesn't have any medical history that he's aware of. Pretty healthy.
Is there anything that makes it worse, like taking a breath in or exacerbated with movement?
Yeah, nothing movement related, honestly. He said he's just been trying to like sit at home. He took some Tylenol, hasn't gotten any better. He asked his wife to put like a ice pack on it, hasn't gotten any better.
I'm going to back it up for a second. What do I see when I walk in the room? How does he look? Like, what are his vitals and how does he look?
Sure, yeah. So he looks really uncomfortable, sitting in the chair, just like kind of making this grimacing face. It's like, it just really kills me. But his vitals are normal. His heart rate is 93. His blood pressure is 128/72, satting 100% on room air.
Temp.
Temp is afebrile, oral temp.
And any other symptoms? So he's like focused on the pain, but has he noticed like waves of nausea, chest pain, belly pain, anything like that along with it?
Yeah, he says honestly that when the pain's getting super severe, he feels a little nauseated, and it feels like it's like rising up in his chest. He's, said it feels like he's had heartburn in the past. He's kind of feeling that sensation too with it. And then he also tells you, like actually in the last month too, I've been having some bad heartburn. So I think it's probably, maybe my heartburn. I don't know.
Tell me. Oh yeah, you go.
Yeah, just like sort of a gestalt question. Like when you look at this guy, we see lots of people with musculoskeletal strain. They played basketball, whatever, soccer. Does he look like that? What's your heart going like? This isn't just a musculoskeletal strain. Can you answer that question?
I'll say that you look at him and you can't tell. This is a guy that's like really not tolerating some, like he's being real soft about some musculoskeletal pain, or he's just very uncomfortable. He just looks uncomfortable, and it's not like, he's moving in the chair. It's not like a stiff person sitting there in back pain, afraid to move.
Is he like can't get comfortable moving around? And those people who come in with like a kidney stone where they just are writhing, they cannot get comfortable. Is that the kind, or
Yeah,
is there a position of comfort?
Great question. He says there's no position of comfort, and he's just kind of sitting there and he's like, kind of going like this, just moving. He stops when you're talking to him for a little bit, and he's just readjusting himself, but he's not like squirming around in the chair like a kidney stone looking guy.
And no priors, any other significant history that we need to know about?
No, no other significant. Well, when you say significant history, you mean like medical, social?
Well,
what
has
else do
he
you want
had
to
a
know?
dissection before? Has he had an MRI?
Just cheat codes.
He says like, listen, I honestly, I'm only 42. I haven't really spent much time in a primary care doctor. I got my blood pressure checked at a CVS Minute Clinic 6
Did
months
you
ago. It was fine.
Coarctation of the aorta as a child.
Yeah, he doesn't know anything about that.
Okay.
But when he was a kid, he grew up in South America. All of his medical records are otherwise fine.
Okay.
That he
It's kind
knows
of
of.
lame, but I still always consider like social history,
Sure.
right? Smoker, drinker, drug user.
Smokes socially every once in a while, enjoys a beer every once in a while, and he does regrettably inform you after you talk for a little bit, he has picked up an opiate addiction from, he started working in this factory a few months ago and eventually had some back pain, was taking some prescription opiates, and then has used some IV drugs actually in the last few months.
Has used IV drugs.
He has. He said it's a pretty new thing.
We just did a
Told you, social history. Don't forget to standardize it. I ask everybody this
I was going to ask to take the shirt off and see if there's a gunshot wound in the back of this boy. It's like, what?
So
yeah, I'm
You're done.
That's it. You're like, I'm sorry, you're doing opiates. Goodbye, sir.
If somebody's doing IV drugs and they've got back pain like that, they need
That's
an
huge
MRI
red flag.
yesterday.
Oh,
This is
red
a
flag.
spinal epidural abscess. This is discitis. This is something bad until proven otherwise. I don't care what his temperature is. I really don't care about anything else. Having been sued for this, what did I say? Having experienced these patients many times, MRI.
That's immediately where my head went as well when I hear IV drug use and back pain. That's certainly concerning. And I'm starting to think this has nothing to do with the soccer game.
Yeah. And before I send this guy off, because obviously this doesn't sound like he's any longer an urgent care player, but I would think as like a measure of safety, because we're still, always keep our differentials broad, right? I would at least want to like do an exam on him and get an EKG so that I can make sure
that seems a little too thorough.
That's so weird. Examine the patient.
If you just let me doctor how I doctor.
So, if you guys are worried about epidural abscess, what are some things on exam you want to know?
What's the MRI? Oh, sorry. I'd like a full neurological exam, and I'd like to palpate over his spine, and I'd like to do lots of shit. But what's his MRI?
Okay. So
And a core temp too.
And a core temp.
Yeah. Exam.
So you do the full head, fingers, knees, and toes dance with the patient in the room. There is zero abnormalities on his neuro exam.
Oh, cancel the MRI.
He's able to walk heel to toe. You ask him to do some other weird Australian things. I don't know, some weird neuro stuff.
Yeah.
He juggles in the room. Perfect. Core temp is, again, afebrile. It's totally normal.
Skin exam.
Skin exam.
He has skin.
He has skin.
There.
There's nothing you can find on his skin.
Can you
Looks
just
great.
clarify, does he have pain midline?
So you press everywhere along his back, and you can't elicit any back pain.
You can't.
Nope. So he's sitting there like in a lot of discomfort, and you're pressing on the spinous processes. Totally fine. The muscles connected to those, totally fine.
Psoas abscess.
Perianal sensation, post-void residual via ultrasound.
Yep, all that stuff is totally fine. You have him go pee.
You know,
comes
one
back,
thing I always think
normal.
about too in
Psoas
young
abscess.
people is like pneumothorax, because that that's in the, that, you know, think about that in the front, but can go to the back. Lungs are attached front and back. So, you know, is there anything on your lung exam when you listen? Does he have equal chest dries, breath sounds? Like, tell me a little bit about that.
Sure. Yeah, he's got great bilateral chest rise. His lung exam is clear everywhere. It sounds wonderful. He's got great heart sounds. Everything else looks okay in your cardiopulmonary exam.
I take my lung exam with a grain of salt. I think I would still EKG chest x-ray just to make sure, because I always think I hear lung sounds everywhere on everybody.
I like
I
that
could be
idea.
wrong.
All right. Want an EKG then?
Yes, please.
Okay. Here we go. So we bring out the EKG O-matic. This is the EKG you get. You have no baseline for comparison. He's just coming into your urgent care. What do we think? We're getting a lot of
Well, I'll start off because I'm
Are you
old.
Is this the epidural abscess? That
Yeah, this guy's still getting an MRI. I don't care if he's even having an anterior MRI. Look,
It's important to
the
think
eyes
about
are
it.
drawn to the fact that he's got a little ST segment elevation in the anterior leads, and so that obviously freaks you out. It's probably going to be benign early repolarization, so I'm going to repeat this multiple times. But, you know, it could be an MI where I could have been fooled, and this guy who's injecting drugs is also having an MI, and maybe he's got endocarditis or something else. So I want to keep an eye on that, and the first thing I'll do is repeat it again in 5 or 10 minutes. Let's do a troop. Let's get this guy to a hospital.
Yeah, I think the interesting thing about this as well is if you look in the anterior leads, those T waves being taller than the QRS is always something that I think about now that we're talking a lot about OMIs that don't have the classic, you know, STEMI morphologies to them. So that still looks more abnormal to me, less likely to be early repol, just because like those T waves being higher than my QRSs would make me feel like this is abnormal EKG.
Totally. So just to summarize, and especially in V2 there, where you're looking, you see those T waves and the overall voltage, the magnitude of those T waves are actually bigger than the overall magnitude of V2, of the QRS complex in V2. We're going to pull up the EKG one more time here so we can see that. So in lead, is that what you're talking about, these hyperacute?
Yes, exactly.
So in V2. Okay. Cool. So anything you want to do at this point for him having this information?
What about, do we get our chest x-ray?
Chest x-ray. Yep, it's coming right up. Here's your chest x-ray. Looks like a chest x-ray.
Yeah, very nah.
Yeah, it's like every
What are you
chest-
looking for on this guy's chest x-ray? He's coming with like this mid-thoracic at the diaphragmatic line back pain. I know you talked about a pneumo a second ago. It looks like his lungs are up.
You look at the
What else?
ribs. you know.
Pneumonia, what are those costophrenic angles doing?
Okay.
Like a lateral, to take a bit of look there. I'm not seeing too
Yeah.
much on this,
Yeah,
but
the lateral looks clear.
And in this case, I mean, I don't think that we expect the chest x-ray to give us an answer, right? Like this is more of a rule out. Like Jessie did mention that she had good breath sounds bilaterally, and this is like further confirmation. Pneumo can be striked off your list as you're kind of searching. And a lot of what we do is more of a rule out. So
Yeah, you don't want to transfer someone with a tension pneumo, you know, you want to see
bad
that, you
look.
want to diagnose that before you send them to the ER, so.
Especially if you're sitting there for MRI for back pain. Oh, well,
that's fine.
good move. All right, so you got this information. He's still sitting in the room going, doc, I just feel really uncomfortable, a lot of pain. What do you want to do?
And you looked at the skin, right?
Yeah, skin exam looks great. No
Okay.
abnormalities.
Well, we're going to get rid of his pain.
yeah,
Give him
so
some
do we
pain,
have-
give him an aspirin. That's not going to hurt anything at this point.
Okay.
Put a line in, call an ambulance, get him to the
Okay.
hospital. What's that second EKG show? What's the troponin? What's that MRI of the spine showing?
Sure. So you don't have a trope at this urgent care. You don't have like a rapid access trope.
Okay.
Your EKG looks about the same for the second one.
Okay.
We can go back.
Vitals, are they changing at all for us? Or they're
Vitals
holding
have stayed about the
steady?
same. His
He's
heart
not
rate is,
tachycardic and nothing.
yeah, it's come up to like 97, you know, but it's never been more than 100.
Is
Why are you
there-
guys asking about the heart rate so much? Just curious.
Well, if this guy's having a big anterior MI, I expect him to look different than the way you're describing him. So you're describing him poorly, or he's a very bad patient. I expect him to
Blame the
with this,
patient. Good rule.
If he's young and healthy with a good sympathetic tone of him to be sweaty, tachycardic, like he's dying if this is his anterior wall is going, and he would look like that. But you keep describing it's like a musculoskeletal thing. So I'm going back to my MRI, but I can't do this in the urgent care. I need to get this guy, everything about this, whether it's an MI, whether it's a spinal epidural abscess or something like that, he's got to go somewhere where he can get this worked up fast. So that's why, you can do another EKG, but I'm calling 911. I want this guy to go.
Yeah. And rechecking the vitals, I think, would be important for me, right? Because you want to know that he's maintaining some degree of stability so that he is safe to transfer, right? You don't want to turn your back while you're trying to get all of these things orchestrated, and all of a sudden your patient becomes more hypotensive or more tachycardic and starts to crump, right?
Totally.
And like with vascular type pathologies, those are some of the things that I would be thinking about as well. So.
I think I would ask him a little more, like earlier on, I would have liked to have asked him a little bit more about his history too. You mentioned like, oh, he's been having some GERD, he recently started IV drugs. That makes me wonder like, am I missing something else? Has he had these symptoms, anything like this
He's
before?
still here. What do you else want to ask him about? When those symptoms have happened?
Great. Yeah, I mean, I would like to know if he's had any other abnormalities in the past few months. I mean, he came here from somewhere else. You know, is he like vaccinated? Has he had any exposures? You know, that would worry me. You know, has he had any other symptoms other than the GERD? Has he had some pain like this ever before? Those kinds of questions.
Totally. And just, I don't want to inappropriately summarize what you guys are saying, but I'm getting the sense that you all feel a little discomfort because this is like some kind of atypical presentation. You're asking for more history. You're asking for like MRIs. You're asking for
ambulance.
And there's not, an ambulance. So there's not like a
Get 'em
clear
out.
box that this person has fit in your mind yet where you feel like, I'm confident at what's actually going on. Is that fair enough to say?
One thing we're confident, this is not musculoskeletal back pain.
Okay.
He is hiding something bad internally
Yes.
that we need to find out about.
And that's the key thing, right, in the urgent care is that you may not entirely know what it is you're transferring or requesting the ambulance for, right? But you've got a guy and the math ain't mathin', right? Like something about the way that this history is coming out. He's got too many red flags that are firing off.
Totally.
And so that's going to be more important than me figuring out the diagnosis in the urgent care is knowing that it's not being put together the right way history-wise to be something benign. He's got to go.
And also not anchoring on this history of, oh, I think it's related to the soccer game. Because you would expect that if this is a traumatic injury, we would be seeing something a little bit more of a slam dunk.
On your exam or like, totally.
Exactly.
I think that's really obviously wise from all of you guys. You know, you ask him a little bit more about that gastritis, dyspepsia stuff. It's so funny. It's like after every soccer game, I've been getting this feeling of like heartburn every time I've been practicing for soccer or running around. But I have like, you know, flaming hot Cheetos before practice. I don't know, maybe it's that.
So is this his anginal equivalent?
I know,
Is this
it's
his MRI?
exertional.
So you guys, so your final thing is you're giving him aspirin, calling an ambulance, sending him out. Is that fair?
That's what I'm
So you'd
doing.
like to do for this guy?
I think that sounds
Perfect.
Let some smart doc work out what's going on.
Yeah. So in real life, in this case, this person was diagnosed with maybe musculoskeletal back pain, maybe dyspepsia, was given some like omeprazole, some antacids, and then presented to an emergency department 2 hours later in cardiac arrest and was in a VTAC to PEA arrest. And then, long story short, when they presented, they got ROSC, took this patient to the cath lab, he had 100% LAD occlusion. So I think you guys picked up like right away on the atypicalness of this case. And I like think it's really hard. Someone comes to urgent care or to any setting saying like, I just had this game, I'm getting this back pain. It's like really atypical location of pain.
He's young. He's
Very
42.
young, no risk factors.
Yeah.
It's like no surprise that this is like one of the cases Mike writes about because it's really challenging. But just describe a little bit more like that tension of like you guys really jumped on early on that this is not just a back pain case. Is it because you're all just really zoned into like diagnosis of exclusion musculoskeletal?
No, I mean, I think it's all the things that everyone kind of picked up throughout the line of questioning and throughout the physical exam, right? If this is MSK pain, then some of those things like reproducible with movement or pushing on it, or Jesse went back to like, oh, this comes up every time it's in their soccer game. The IV drug use being some of the risk factors for more scary, dangerous things. This is not just the classic guy that like strained his back, and so I don't know, I just...
Yeah, totally. It's like something doesn't add up about it, especially to like any thoracic or high lumbar with back pain, you're getting very concerned there, right? Because you know that that's like PEs, low-lying PEs can hang out in that space and cause like referred pleuritic pain. You said pneumonia at one point was thrown out. Like there's a lot of...
He said dissection.
Yeah, weird stuff. Like thoracic back pain is like not super normal for people to have, especially unless they have like a traumatic thing that's occurred. It's definitely a red flag.
I also
To
like
me
how
anyways.
Mel pointed out, you know, if the EKG is not normal, you should repeat it.
Yeah.
You should get another one in 15 minutes.
If we could pull up that EKG one more time, this was not the one that's associated with the case, but I purposely picked one that's like, this is like a hard one, right? Like you guys threw out benign early repole versus like an early like anterior STEMI. And definitely in 15 minutes, I'd hope that this would evolve for those of us that aren't as tuned into those subtle findings that y'all pointed out. But it's really tough, right? It's, you know, a really, really difficult EKG to pick up out of nowhere, not having a baseline for them. But for me, the thing that really makes me concerned is what we talked about, these acute T waves, right? How they're bigger than that QRS. And then also there is a decision tool to help you with benign early repol versus like possible STEMI that looks at the QRS morphology and that little like terminal deflection, or the fact that there are some Q waves that you can see in this EKG that could suggest that it's more ischemic than it is benign early repol. But I'm glad you guys were like, that was the first reaction. Like you were hoping this was just gonna be a normal sinus, like nothing EKG, you know?
Yes, so Stuart's got a great EKG series, and he goes through the causes of ST elevation, and he talks about the different ones. And benign early repolarization can look like an MI. That's why he's bashed that into our heads a million times. Just keep doing the EKG. It's a dynamic process. So that's why I want another one, another one, another one. But I think the key thing for me is something like this is the gestalt thing. Like you walk into the room and like, you know, just musculoskeletal pain, you see a lot of people and they're not looking like this guy. You did a good description of like, there's something wrong. And I think you're trying to say, there's more than just, he hurt his back.
It's being a little cheeky, but yeah.
Yeah, so not having the right diagnosis, I don't care about getting the right diagnosis. It's like, I just want to make sure, sick or not sick. Sick? Uh-oh, let's go do some extra things, and the smart people work it out faster than the dumb people. But all I care about is that first part, sick or not sick. And you gave us the impression that there was something bad there. Yeah. It's a terrible case. 2 hours later in full arrest.
Yes.
Yeah.
Well, and the other big teaching point about that, and I think what we were all trying to pull away from, but something that, you know, for early learners and for all of us is like avoiding that anchoring, avoiding that premature bias that you get from like the triage note or the chief complaint, right? Like back pain after a soccer game, that could have totally made you just like try to poo-poo this case, right? Like, here's your Tylenol, here's your Motrin, go home. And then he presents PEA arrest, right?
Yep.
Versus actually taking the time to dig through some of the historical components that make it not sound like just an MSK back pain. And I know with volumes being high, it's like hard to do, right? But don't anchor, don't prematurely close, like actually take the history, do the physical.
And I love that you brought up the social history, right? Like that was the first thing you guys were like, oh, we're taking a left turn here. Because, you know, but like it's so easy when the waiting room's packed. It's a young, no medical history guy that comes in with a good setup for a musculoskeletal thing to be like, yeah, I don't care if you like, you know, live in a house of 50 people, like whatever, who cares? We'll skip that, here's your Tylenol. And like just going back to those basics is so important, and being thorough about it, you know.
It's really key. And when we see somebody who's an IV drug user, again, there's two types of people. There are those people like they're just trying to get drugs from me and this is all an act. I have the exact opposite response. If you do IV drugs, everything as bad is going to happen to you. You know, we see so many of them now in our city hospitals. And somebody comes in with IV drug use plus anything, I'm like, oh shit, this person's going to have something terrible. That's my response. Yeah, you might want to have my drugs, but you probably also got endocarditis.
Turns out,
you've got everything.
Statistically, they have a higher chance of having something terribly wrong, right? So it's a weird situation. You know, Mike recorded a little bit about this case. Let's hear what he has to say about it.
Hello. First is correlating chief complaint with final diagnosis. And I know, I get it, myalgia's maybe related to that chief complaint of upper back pain, but when we think about any complaint that we have, if it's elbow pain, just for example, we think about the joint proximal and the joint distal. In the same way, the upper back is part of the chest. And just as that can be from something like a back strain, certainly it could be from other things like acute coronary syndrome or even pulmonary embolism or, for example, a thoracic aortic dissection. The other thing that's really important to think about anytime that we're seeing a patient is when we don't have the adequate data on which to base our decision, we're not going to be able to come out with a good decision. And in this case, there really was almost no history of present illness. And the history of present illness for me, with the medical legal case that I've done, almost 80 of these cases now, that's the main part that's missing when I look back on these cases where there are misses and they went to medical legal action. History of present illness, onset, duration, location, exacerbators, relievers, all those types of things. Obviously, based on the chief complaint, those can be different levels of importance, the data that we get there, but certainly we need to gather adequate data on which to make our diagnosis. And finally, when I think about any patient that I'm seeing where there's some amount of diagnostic uncertainty, in addition to, as I've said in the past, making sure the patient understands that amount of diagnostic uncertainty, in addition to that, we want to make sure that we think about something in a global way, and it could be a little bit indelicate in a certain way, but what happens if this patient bounces back horizontal and room temperature, in other words, dead, in 24, 48, however many hours? What did I miss? And before that patient leaves, to think to ourselves, what are those diagnoses I need to make sure are not occurring? And in this situation, if we would have done that, if we would have gathered adequate data, and maybe even if we had done that hard stop in the medical decision making, where we explained why we didn't think those things were going on, it would have caused us to think about the fact that they could have been going on, and ensured that we not only gathered adequate data, but explained that in that medical decision-making note, because certainly in this case, there was some diagnostic uncertainty. All these things together don't take tons of time, but absolutely can make our patients safer.
Awesome. Well, thank you, Mike. You know, I think that sometimes it feels like a bummer to end on a discussion about something terrible that happens to people. I don't think anyone here wants to practice medicine where we're like terrified of missing a thing that's going to kill somebody, even though most of the time I am pretty terrified.
Yeah, I was gonna say that pretty much every shift.
Yeah, sure.
State of being.
You know, I think like the takeaway here is like do the thoroughness that we all like we're talking about, and not discounting and prejudging what the patient's coming in for at the beginning. And I mean, it didn't take you guys long, obviously, in this setting, without 50 other things nurses are asking you for to come to a safe disposition for that patient. So
I'm just going to need you all to come to shift with me from now on.
You know, a lot of people in the chat here are saying the same thing, that having people go through a case like this is really good. This is why we're trying to do this, is because reproducing rounds, having people discuss these cases is one of the best parts of residency. So that's what we're trying to do. And if there's other parts of this program that you really like or you don't think is working, let us know. This is a dynamic thing. We really want to make this rounds something that's lifelong, that you don't just do during residency. And rounds was always the best to me. And M&M conference was always the best. Like, let's all talk about how we screwed up, because you can learn so much from other people's screw-ups as well as your own. So give us some feedback in the chat here or email us. But I thought it was fantastic.
Totally. Especially too if you have like a case or something you'd like to see us work through. Because I really think, although it's very stressful for everyone up here to go live in front of you guys and talk about a case that they have no idea about, it's not like patients come in with like, here's the pre-written case summary for what you'll be treating me with today. And so we really are trying to capture that real clinical reasoning and decision making.
I also find it very upsetting that most people said that I would come last, and they were correct in Jeopardy. I'm never doing it again.
They're just judging your reflex time on the button, I think.
No,
You know,
I
that's
thought
what it was.
I was holding it, then I was letting it go. I'm like, I'm not so good.
Well, we had earlier this evening the clinical image. We've been sitting on the edge of our seat.
Yeah.
Yes.
What is that?
Okay, where is it? Let's bring it up.
We're pulling it up right now.
The clinical image of the evening is a green stick fracture, and this is really a pediatric fracture. The reason it happens in kids is because kids have really bendy bones, and this is just a sort of partial fracture. Doesn't go all the way through the bone, happens on the convex side of the bone. And if it's very displaced, very angulated, you can go ahead and reduce it and put the child in a cast. Sometimes these really don't need anything, and there's nothing to put back into place. It can be pretty well aligned, not super displaced, not super angulated, and sometimes they don't even really need follow-up. But if it is, and you end up, if you do any sort of reduction and then splinting of that child, they do need some ortho follow-up just to make sure that everything has healed well. And so the winner of tonight's clinical image is Kevin Glug. Is that right?
Klug.
Kevin.
Kevin.
Kevin. We're going to put
He's a good and nice person.
So Kevin, we'll reach out to you, send some details so we can get you those AirPods.
Yes, coming to Kevin.
Awesome. Any other last hot button pressing issues, questions, comments, concerns? Anything blown up in the chat?
No, not really. Just sign up for UC Maximus. This is what we do. Lots of conferences, lots of conferences I need to watch apparently because I come last in Jeopardy. We have podcasts, we have textbooks. It's a great show.
Right on.
And we'll see you all in a month or so.
The next one's coming up January 10th, I believe is the date. That'll be our EM Grand Rounds. We alternate, for those who are new to the Grand Rounds experience here, between urgent care and emergency medicine. To be honest, like, it's good for anyone who practices medicine.
It's great for both.
Check it out for some more fun. And don't feel like a stranger. Go ahead and subscribe down below so you know when these are coming. Click the little bell, get the alert. Every month we're trying to send out AirPods to a new subscriber we pick at random to give you some bonus to hit that little button and to check in every once in a while. I know I lose AirPods like every month. I should just start doing this because I think I've gone through 3 pairs since we started getting them away. It was just terrible. I also want to give a huge shout out. The whole studio has been redesigned. The production team has busted their butt over the last several weeks, including all day today, all weekend to make this show happen. There's a whole bunch of people that aren't up here making fools of themselves. Jeoparty, that we owe thanks to, they're making a fool of themselves on the other side of the camera. So you don't get to see that. But nonetheless, it wouldn't happen without them. So thank you to all those guys. We're going to roll the names right now, and we'll see you next time on Grand Rounds.
Thanks.
Thanks, everybody.